This gentleman presented to us with a nuclear cataract in both the eyes, and the complexity was regarding the biometry. This patient had undergone a refractive surgery known as radial keratotomy several years back, nearly 40 years. And now this patient needed a cataract surgery, and for which we have to calculate the IOL power which would be appropriate. This is the right eye fundus, and this is the other eye which had a similar cataract, and this had a worse situation because the fundus was not so good and there was a chorioretinal scarring at the posterior pole. This must have been secondary to myopia. The issue with these patients is discussed very well in this panel discussion which is available on internet, and this is the QR code, one can scan and visit that. I'll just highlight few salient issues associated with the radial keratotomy patients. The good thing about these patients is that the corneal thickness is not changed, because these radial incisions don't alter the thickness of the cornea, and as a result, as we all know, the lens power for any given lens would depend on the refractive index, the anterior and posterior curvature, and the thickness. The problem is that these IOL power calculation formula, they presume the cornea to be having a uniform thickness which is standardized about 0.5 millimeters at the center, and also having the posterior and anterior curvature to be same. So once the keratometry has been done, the same is applied on the posterior surface of the cornea. The problem arises when you have a refractive surgery which has removed a portion of the central cornea, and this changes the thickness of the cornea and also changes the agreement between the anterior and posterior curvature of the cornea. However, in these patients, pre-refractive surgery details are never available, because usually these patients present to us at a very later stage and the biometry accuracy is always in question. The article which I have mentioned throws some light on this, and here we can see this patient's IOL power calculation sheet, and I have used universal Barrett 2 formula which takes into account few more issues which make the power calculation more accurate. One factor which comes into in these patients is because the central cornea gets flatter because of the peripheral bulging, the anterior chamber depth becomes relatively shallow, and this has to be incorporated in the IOL power calculation formula which this formula uses, and as a result we are more close to the actual situation and we have a more accurate IOL power calculation. These patients also tend to have slightly hypermetropic refractive outcomes, so a myopic IOL power selection is ideal. So in this patient, a 21 diopter of power was calculated and selected to be the choice, keeping in mind nearly 0.5 diopter of myopia. This patient requested a bifocal IOL, and that was evident because this patient was concerned about the refractive errors. Here is the point where we are starting the surgery, placing the corneal incision at the steep axis, and at this moment we can appreciate the radial keratotomy scars visible in the cornea in the mid periphery. Making the incision, and this is being a nuclear cataract, grade 3 should not be a difficult task. Instilling intracameral lignocaine. This video is not about performing cataract surgery but having accurate biometry and IOL power calculation and post-operative predictable refractive errors. A good capsulorhexis is must for any given case, same goes for this. So as usual, I usually lacerate the capsule using the rhexis forceps itself and propagate the rhexis using the same forceps. This being a situation where the steep axis was onto the 127 degrees, so it was for a right-handed person, it was a situation which was very ideal. Doing hydrodissection and hydrodelineation to define the nucleus. In nucleus grades less than 4, one can always define the nucleus which separates the epinucleus and the nucleus. Performing the surgery, going for the first chop. This portion of the video is being run at 1.5 times the normal speed just to expedite this process, which is not so important for this particular situation, where here we are more concerned about issues arising during the surgery in these patients who have had radial keratotomy, which universally weakens these cornea in these scar areas. So one has to be vigilant, although in this patient no unwanted accident happened that any scar would have ruptured or dehiscence in the cornea was not seen. Nucleus has been removed, removing the epinucleus, and now going for the cortical removal plus some epinucleus which has been left behind. Myopic patients will always have that risk of deep AC, a thin capsule, and a risk for posterior capsular tear. So one should be vigilant and also take care that appropriate tool is used. So using IA cannula is much safer compared to the phaco tip to remove the cortex and epinucleus. Here the epinucleus and the cortex has been removed, and now we are left with a capsular bag into which we will implant our intraocular lens. This is a bifocal lens, and the IOL goes into the bag, the leading trailing both the haptics. This is the day 1 post-op picture. The cornea is clear, and we don't usually refract the patients on day 1. However, we do refract the patients on day 7, and this is the day 7 picture which shows a clear cornea, good visual recovery, and this patient had astigmatism of 1.5 diopters. There was no residual spherical error, and this is good for the patient because the biometry was accurate as predicted by Universal 2 formula, and I would recommend that to be used in these patients who have undergone radial keratotomy. Thank you.